When you break an arm, the diagnostic process is, well, it's essentially binary, right?
Right. Yeah, very clear cut.
Yeah, the x-ray lights up, you see that jagged white line, and the doctor says, there it is. It's a visible, contained problem. But step into a high-risk delivery ward, and that precision just completely vanishes.
Oh, entirely. It's gone.
You are no longer diagnosing a single stable patient. You're monitoring this delicate, hidden, uh, constantly shifting ecosystem.
It is the absolute definition of diagnostic muddy waters. I mean, every intervention, every test, it has to account for two interconnected lives.
Exactly.
And, the physiology is literally changing by the week.
And that is our mission for this deep dive, because out of the 3.6 million births in the U.S. in 2020, a really significant portion were considered high risk,
Yeah, quite a lot.
meaning the health of the mother or the fetus was actively jeopardized by the unique circumstances of that pregnancy. So for you, the learner, we are going to decode exactly how modern medicine navigates those muddy waters using a comprehensive clinical management framework.
It's a fascinating framework, really.
Okay, let's unpack this, because before we even get into the heavy machinery of fetal monitors and genetic sequencing, we really have to establish what risk actually means.
Yeah.
Because it's not just a list of medical conditions anymore.
Far from it. I mean, the historical view of obstetrics was incredibly narrow.
Right.
A doctor would check if the mother had a physiological illness like diabetes or hypertension and basically just stop there.
Like checking a box.
Exactly. But today, clinical management operates on a framework of 4 interrelated cumulative pillars. So we're talking biophysical, psychosocial, sociodemographic, and environmental. And these risks, they stack on top of each other.
Like the foundation and environment of a house. So let's map these out, starting with the biophysical pillar. This is the physiological baseline, right? We're talking about genetics, pre-existing medical disorders, and nutritional status.
Right, the internal physical stuff.
Yeah. For example, a major biophysical red flag is a hematocrit value dropping below 33%. Now, hematocrit is the measure of red blood cells in the blood, and during pregnancy, a woman's overall blood volume essentially doubles.
Which naturally dilutes her red blood cells.
Right, exactly. But if it drops below that 33% threshold, she is severely anemic. The mother's blood physically lacks the required oxygen-carrying capacity to, support the metabolic demands of the fetus.
Exactly. It's a direct mechanical failure of the supply line. But then you layer on the psychosocial pillar, which encompasses behaviors and emotional status.
So things like smoking and drug use sit here.
They do, but so do everyday variables that we can heavily quantify. I mean, caffeine is a perfect example of this.
Oh, right. The data shows a very strict threshold here. Pregnant women consuming more than 200 milligrams of caffeine daily.
Which is roughly a standard 12-ounce cup of coffee.
Now, just one cup. They have a markedly increased risk of giving birth to infants with intrauterine growth restriction, or IUGR.
And the mechanism behind that is really critical to understand because caffeine easily crosses the placenta, sure, but more importantly, it acts as a vasoconstrictor.
It tightens the blood vessels.
Literally tightens and narrows the mother's blood vessels. So when those vessels constrict, you are physically reducing the volume of nutrient-rich blood flowing through the placenta over 9 months, that daily restriction compounds.
Mhm.
And the baby's growth stunting is the direct result.
That makes total sense. Then we have the sociodemographic pillar, which contextualizes where and how the family actually lives, income, maternal age extremes like adolescents or mature women over 35, and severe structural disparities.
Yes, the structural disparities are huge.
There's a stark reality in the demographic data here. In the United States, Black women experience rates of preterm birth almost twice as high as those of other racial and ethnic groups.
Which forces clinical medicine to acknowledge that structural inequality carries literal biological weight. I mean, chronic psychosocial stress, restricted access to early prenatal care, and the physiological weathering of systemic racism.
It changes the body.
It physically alters inflammatory pathways in the body, which can trigger the exact mechanisms of early labor.
It's all connected. If the neighborhood is toxic or the foundation is shaky, the plumbing inside is going to struggle regardless. And the final pillar, environmental, really proves it's not just about the mother's immediate biology.
Right, it's external.
This covers workplace hazards, radiation, infections. But, and this blew my mind, it also includes paternal exposure to mutagenic agents.
Yes, the father's environment.
Right. If the father is exposed to specific heavy metals or chemicals in his workplace, it can actually damage the DNA in his sperm, which is directly associated with an increased risk for miscarriage.
It's incredible. If we connect this to the bigger picture, this overlapping complexity is exactly why antepartum testing operates with two very distinct goals. The first is what you'd expect, right? Identify the fetuses at active risk of oxygen loss so you can intervene before there's permanent injury.
Catch the problem early.
Right. But the second goal is arguably just as critical. Definitively identifying the healthy, appropriately oxygenated fetuses so you can prevent unnecessary medical meddling.
Ah,
You do not want to trigger a premature delivery if the ecosystem is actually compensating and functioning well.
with risks being this cumulative, that dual mandate makes perfect sense. So with that foundation laid, let's move into the actual diagnostics. Because the risks are so varied, monitoring starts with the simplest, least invasive physical checks before escalating.
Definitely.
The absolute first line of defense is the daily fetal movement count, what we commonly call the kick count.
Right, and it relies entirely on maternal sensation. The presence of fetal movement is a highly reassuring indicator of a healthy, functioning central nervous system.
So how do they measure it?
Well, a standard protocol is having the mother count movements for 60 minutes a day. The critical clinical threshold, the so-called fetal alarm signal, is defined as 12 straight hours of absolutely zero movement.
Now, I want to jump in on the kick counts, though, because the clinical protocols warn about false alarms here. The interpretation isn't always straightforward, is it?
No, it's not.
Because there are maternal factors that can physically mask these movements. Like, if a mother has a higher body mass index, the extra tissue naturally dampens her physical perception of the kicks.
Yes, exactly. Or, if she's taking central nervous system depressants or smoking.
Right.
Those substances cross the placenta and temporarily suppress the baby's activity. So the baby might just be asleep, not in distress.
Which is terrifying for the mother, but biologically explainable.
That is precisely why the kick count is only a baseline screening tool. The moment a mother reports decreased activity that hits clinical concern, the care team immediately escalates to diagnostic ultrasonography.
And the physics of ultrasound are just fascinating. It uses high-frequency sound waves operating well above 20,000 hertz.
Completely silent to human ears.
Right. The machine pulses these sound waves into the body. They bounce off the varying densities of tissues and fluids, and the machine basically calculates how long it takes the echo to return to map out an image.
And we are no longer limited to standard 2D imaging either.
No, the tech is wild now.
It is. The technology has advanced to 3D, which calculates the echoes from multiple angles simultaneously to render depth, and 4D, which adds the dimension of time.
It's like a live video.
Exactly. It provides a live, continuous stream of the fetus moving in real time.
The logistics of how they capture those echoes matter immensely, too. Early in the first trimester, they use a transvaginal approach. It bypasses the thick layers of the abdominal wall entirely, and it can pick up the tiny flicker of a fetal heartbeat as early as 6 weeks.
Yes, very early.
But later in pregnancy, they shift to the transabdominal approach. And there is a very specific, almost bizarre physical reason doctors require patients to show up with an uncomfortably full bladder for this.
Oh, it's terrible for the patient, but mechanically genius.
Right, because the bladder sits right in front of the uterus. When it is completely full of fluid, it acts as a perfect acoustic window.
It literally physically displaces the uterus, pushing it up out of the pelvic cavity.
So the ultrasound waves have a clear, liquid medium to travel through without scattering.
It's brilliant practical physics. And once they have that clear acoustic window, the clinicians aren't just looking around, they are taking highly specific biometric measurements.
Like what?
Once in the first trimester, measuring the crown rump length, so from the top of the head to the bottom of the torso, is the single most accurate method for establishing the exact gestational age. And they also perform neutral translucency, or NT screening.
I want to focus on the NT screening because the mechanics of it are incredibly revealing. They use the ultrasound to measure the precise collection of fluid at the nape of the fetal neck.
Right at the back of the neck.
Right. And if that specific fluid pocket measures over 3 millimeters, it acts as a soft marker for chromosomal abnormalities like Down syndrome.
Yep.
And why there? Because certain genetic conditions actually delay the development of the fetal lymphatic system. So fluid naturally backs up and pools at the back of the neck before the lymph nodes are fully functional.
It's an elegant physical clue to a genetic reality. The clinicians are also meticulously measuring the amniotic fluid volume.
Which changes over time, right?
Yeah, by the second trimester, amniotic fluid is predominantly composed of fetal urine.
Wow.
So this gives us a direct window into fetal organ perfusion. If the ultrasound shows oligohydramnios, meaning there is too little fluid, which is defined by a vertical fluid pocket of less than 2 centimeters, it tells us the baby's kidneys aren't producing enough urine.
Which means the baby's body is likely shunting blood flow away from the kidneys and toward vital organs, like the brain and heart, due to chronic oxygen deprivation.
Exactly. It's a survival mechanism. And conversely, if there is polyhydramnios, so too much fluid, with pockets measuring greater than 8 centimeters, it suggests the baby might have a gastrointestinal obstruction preventing them from swallowing the fluid. Or it points to maternal complications like uncontrolled diabetes.
Both extremes of fluid volume are massive red flags requiring immediate clinical intervention.
These absolute red flags.
Now, I have to push back on the technology itself for a second. If 3D and 4D ultrasounds are this advanced and the imagery is this amazing, why do the major medical societies so aggressively discourage families from visiting those boutique non-medical ultrasound clinics just to get keepsake photos?
It's a great question, and it comes back to the underlying physics we just discussed.
Yeah.
Ultrasound is not a camera.
Right.
It is high-frequency acoustic energy entering biological tissue. It generates microscopic amounts of heat and can cause cavitation, which are tiny vibrations in the tissue.
Oh, right.
Yeah. While it is universally considered safe when used diagnostically, exposing a developing fetus to thermal energy solely for entertainment, without any clinical benefit, it violates core medical principles.
That makes a lot of sense.
Furthermore, untrained operators at these boutiques are notorious for misinterpreting shadows. They cause massive unnecessary panic, or worse, they provide false reassurance when there is a legitimate anomaly.
So we'll leave the diagnostic tools to the diagnosticians.
Exactly.
But here's where it gets really interesting. Ultrasound is incredible for mapping the physical structure. It shows us the bones, the fluid pockets, the literal architecture of the pregnancy.
Yes.
But what if the problem is in the wiring? What if we need the exact genetic blueprint? Or we need to know if the baby's lungs are biochemically mature enough to breathe air? Sound waves can't bounce off a chromosome.
No, they cannot.
We have to pivot from the biophysical to the biochemical.
We have to move past visual representation and directly sample the genetic material and the fluids. And for decades, achieving this required invasive procedures. The classic example is amniocentesis, typically performed after 15 weeks of gestation. A needle is guided transabdominally directly into the uterus to extract a sample of amniotic fluid.
And the chemical analysis of that fluid is just mind-blowing. They can test for neural tube defects by measuring alpha-fetoprotein levels. But the true marvel is how they assess lung maturity.
Oh, the lung maturity tests are fascinating.
Yeah. They look at the LS ratio, or conduct a lamellar body count. And what they're actually doing is measuring surfactants. Inside the baby's lungs, the tiny air sacs, the alveoli, are like the insides of a wet balloon.
That's a good way to picture it.
If a baby takes a breath, the walls of those wet balloons will just stick together and collapse without something to lubricate them. Surfactants are those exact slippery lipid proteins that prevent the lungs from collapsing.
Right.
So if the amniocentesis confirms the surfactants are present in the fluid, the doctors know the baby will physically be able to process oxygen in the air.
It is a profound biochemical guarantee. And if they need genetic answers even earlier than 15 weeks, they use chorionic villus sampling, or CVS.
Okay, when is that done?
Usually between 10 and 13 weeks. This involves taking a microscopic biopsy of the actual placental tissue, either transcervically or transabdominally.
But both amnio and CVS carry a severe warning in the clinical text, right? The risk of fetal-maternal hemorrhage.
Yes, it's a significant risk.
Because when you puncture these highly vascular areas, there is a distinct chance that the fetal blood cells will mix into the maternal bloodstream.
Exactly. And if the mother has an Rh-negative blood type and the baby is Rh positive, her immune system will recognize the baby's red blood cells as foreign invaders.
And it'll start producing antibodies to attack them.
It is a critical hazard, which is why standard clinical protocol mandates administering a specialized medication called RhoGEM to Rh-negative mothers undergoing these procedures.
And what does that do?
It essentially hides the fetal cells from the mother's immune system, preventing that immune cascade entirely.
It is a highly calculated risk. But in 2011, obstetrics experienced a complete paradigm shift with the introduction of cell-free DNA screening, or cfDNA.
Oh, a total game changer.
Right. This non-invasive test effectively bypasses the need to puncture the uterus for initial genetic screening.
The underlying biology of cfDNA is remarkable. As the placenta grows and remodels itself, cells naturally die off and release tiny degraded fragments of fetal DNA directly into the mother's bloodstream.
I love this analogy for cfDNA. So imagine standing downstream in a rushing river, the river being the mother's bloodstream.
Okay.
By simply scooping up a single bucket of water, the laboratory can perfectly identify the exact species of trees, the fetal DNA fragments that are dropping their leaves miles upstream.
That's beautiful.
You never have to hike up the mountain or, in this case, invade the uterus to understand what is happening at the source.
What's fascinating here is the sheer precision of analyzing that bucket of water. When analyzing for trisomies 13, 18, and 21, trisomy 21 being Down syndrome, cfDNA operates with an accuracy rate of over 99%.
That's incredible.
But, it is governed by strict biological rules.
Right, it's not magic. The laboratory requires the fetal DNA fraction, which is the amount of fetal DNA relative to the mother's DNA in that blood sample, to reach an absolute minimum of 4%.
Exactly. And that 4% threshold is typically only reached between 10 and 13 weeks of gestation. If a clinician draws the blood too early, there simply isn't enough placental shedding to run the assay.
It just won't work.
Great. Furthermore, maternal biology plays a huge role. If a mother has severe obesity, her increased total blood volume significantly dilutes the fetal DNA fraction.
Oh, making it harder to find the 4%.
Exactly, severely reducing the sensitivity of the test and often resulting in a failed raid.
Still, over 99% accuracy from a standard venous blood draw is staggering. It sounds perfectly definitive.
Well, it sounds definitive, which is exactly where clinical communication becomes vital. Because cfDNA is exclusively a screening test. It is not a diagnostic one.
Yeah.
It is extraordinarily accurate at calculating risk, but it does not diagnose a chromosomal anomaly with 100% certainty. A positive result on a cfDNA screen unequivocally requires a follow-up amniocentesis or CVS.
To physically culture the cells for absolute diagnostic confirmation.
Precisely.
Okay, so let's track our progress here. We've established the foundational risk pillars. We've assessed the physical architecture using ultrasound, and we've verified the genetic and biochemical blueprints.
Right.
Now we enter the late game, stress testing the system. Because ensuring the fetus is genetically sound doesn't guarantee they can survive the actual physical trauma of delivery.
Not at all. Because labor, by its very nature, is a prolonged period of intermittent oxygen deprivation. Every time the uterus contracts, it squeezes the blood vessels, temporarily pausing the flow of oxygenated blood to the placenta.
Like holding your breath underwater.
Exactly. To survive that gauntlet without brain injury, the fetus's central nervous system and cardiovascular reserve must be highly robust. And we evaluate that resilience using late pregnancy electronic fetal monitoring.
The primary tool here is the non-stress test, or NST. And the physiological logic is perfectly straightforward. When you go for a sprint, your heart rate spikes to meet the oxygen demand.
Right.
Similarly, when a healthy fetus moves its body inside the amniotic fluid, its heart rate should demonstrate clear, quantifiable accelerations.
Clinicians monitor the mother's abdomen, looking for those specific accelerations as proof of an intact, responsive central nervous system.
But fetuses have sleep cycles, don't they?
Oh, absolutely.
Right.
Sometimes the baby is simply in a deep, quiet sleep state and won't move. In those cases, clinicians utilize vibroacoustic stimulation, or VAS.
Which sounds intense.
It's basically pressing a device, essentially a modified laryngeal stimulator, against the mother's abdomen. It sends a sharp burst of sound and vibration directly through the amniotic fluid.
Wow.
It is quite literally buzzing the belly to wake the baby up and force a neurological response.
But what if the baby doesn't wake up? What if the NST is non-reactive and there are no accelerations?
Then the care team has to escalate to the contraction stress test, the CST.
And the mechanics of this are intense. They intentionally simulate the physical stress of labor by triggering uterine contractions.
Yep.
They do this either through nipple stimulation to release natural oxytocin from the brain, or by administering synthetic oxytocin intravenously. Then they watch the fetal heart monitor like hawks to see how the heart handles the squeeze.
It's a very stressful test.
Now, I have to push back here. If a pregnancy is already classified as high risk, if the ecosystem is already fragile, why on earth would clinicians intentionally induce contractions? Doesn't that risk throwing the mother into premature labor?
It is a highly aggressive diagnostic maneuver, which is exactly why it comes with a strict list of absolute contraindications.
Okay.
If the mother has placenta previa, where the placenta covers the cervix, or if she has a known high risk for preterm labor, a CST is completely off the table.
You would even risk it.
Never. But for other specific risk profiles, it is the only viable method to test the placental reserve.
Because the contraction physically clamps down on the uterine arteries.
Exactly. The contraption temporarily starves the placenta of fresh blood. A healthy fetus has enough oxygen banked in its system to easily ride out a 60-second squeeze.
But if the fetus is already bordering on hypoxia,
That contraction completely empties their oxygen reserve. As a result, the fetal heart rate will drop dangerously after the contraction peaks. This is a pattern known as a late deceleration.
okay, so
Ironically, when performing a CST, a negative result, meaning no late decelerations occurred, is the exact outcome you are hoping for.
that makes perfect sense. It is a literal stress test of the oxygen banking system.
Yeah.
But if clinicians need a comprehensive assessment and cannot safely trigger contractions, they deploy the biophysical profile, or BPP.
Yes.
This is essentially a full neurological and physical exam of a patient you cannot physically touch. It combines the NST with a detailed ultrasound to score 5 precise parameters: fetal breathing movements, fetal body movements, fetal tone like watching the hand forcefully open and close, amniotic fluid volume, and the reactive heart rate.
It is the ultimate synthesis of our diagnostic tools. The movement, tone, and heart rate confirm the immediate real-time status of the central nervous system.
And the fluid.
The amniotic fluid volume provides a historical record of how well the placenta has been perfusing the kidneys over the past several weeks.
So what does this all mean? We have meticulously detailed the science, right? The cascading risks, the acoustic physics of fluid displacement, the biochemical surfactants, and the vascular mechanics of triggering contractions.
It's a lot of science.
It is. But we cannot lose sight of the fact that this intense, relentless monitoring is not happening to a machine.
No, it's not.
It is happening to a highly vulnerable human being. Being medically labeled as high risk extracts an enormous psychological toll.
It fundamentally rewrites the experience of pregnancy. The clinical label instantly removes the expectation of a normal, joyful process.
It's replaced with fear.
Yes, replaced with a profound sense of physiological vulnerability. Mothers frequently experience intense anxiety, a sense of bodily failure, and severe emotional detachment. Many become terrified to bond with the pregnancy or even set up a nursery.
They're just bracing themselves for a catastrophic outcome.
Exactly.
And the way this avalanche of highly technical data is communicated matters deeply. The data shows that poorly communicated diagnostic results or a lack of emotional support correlate with severe long-term sequelae, including postpartum depression and substance use disorders.
It shifts our entire understanding of clinical care. A nurse managing a high-risk patient isn't just a technician hooking up a fetal monitor.
No, definitely not.
They are actively translating terrifying medical jargon into human empathy.
Which is such a critical skill.
This raises an important question about the architecture of modern healthcare. How do we support the psychological ecosystem while managing the physical one? This necessity has driven the development of fetal care centers. These are specialized, comprehensive hubs that deploy interprofessional teams, so not just maternal fetal medicine specialists, but genetic counselors, social workers, chaplains, and care coordinators.
All working together.
Right, because when a family receives an abnormal cfDNA result, they are instantly thrown into a labyrinth of agonizing ethical decisions about continuing a pregnancy. They require expert translation, sometimes utilizing specialized medical interpreters, to guarantee that their decisions are rooted in true, comprehensive, informed consent.
It is an incredibly intense journey. For you, the learner, understanding the biological mechanisms behind these protocols demystifies one of the most rigorously monitored medical events a human body can undergo.
It really is unparalleled monitoring.
We've traced the logic from the ground up, mapping the overlapping force fields of the 4 risk pillars, deploying the physics of sound waves to verify structural integrity, scooping microscopic DNA from a river of maternal blood to read the genetic blueprint, and finally, intentionally stressing the placental vascular system to guarantee a safe arrival.
And as we close this analysis, consider the trajectory of this technology.
Okay.
The rapid evolution of cell-free DNA testing is actively rewriting the boundaries of diagnostics. If we can already isolate the fetal genetic code with over 99% accuracy for major trisomies simply by drawing the mother's blood, we are rapidly approaching an era where invasive, physically risky procedures like amniocentesis may become entirely obsolete.
Wow. That changes everything.
It fundamentally alters the risk profile of diagnosing risk itself. How will the psychological and physical reality of pregnancy transform when we can map nearly every aspect of a baby's health from a completely standard blood draw at just 10 weeks gestation?
It is a profound shift to consider. It's as if that broken X-ray machine we started with is finally being repaired. The diagnostic muddy waters of the high-risk ecosystem are clearing up, one microscopic DNA fragment at a time. Thanks for diving in with us and keep exploring.